morning. Good morning.
Good morning.
The commissioner got a lot more than that. Good morning.
Good morning.
All right, everyone had their second cup of coffee? We're ready to go? Terrific. I'm Kathy Fisher, and I'm with the Center for States. I'm one of the waiver organizational consultants working for the Center of States to support all of you in your implementation of the 4E waivers. So I want to welcome you this morning to our session on evidence-based practice implementation, responding to organizational and workforce challenges. As a part of our session today, hopefully you've all seen sort of a brief outline of what we're going to be talking about today. So if you're in the session because you thought we were going to talk about selection of evidence-based practices, check with my panel, we're not going to talk about that. So that's obviously been a lot of the discussion in the early days of waiver work has been the selection of evidence-based practices. We're fortunate that many of our states have gone much deeper. As you saw the introduction this morning around the country, we have states that are in various stages of their work on the waiver, and this is an opportunity to really bring some of what we've learned so far, sort of that someone talked this morning about sort of not lessons learned, but what we're learning around the implementation of evidence-based practices and how states have begun to address organizational and workforce challenges. The evidence-based implementation and the implementation of evidence-informed practices in child welfare really begun to take hold across the country. As I was planning for this session with some of my colleagues, we looked a little bit into the research and the things that have been published about evidence-based practice in child welfare. I'm not big into the research. Many of you know me in the room, and I'm sort of a real practice-oriented person around organizational and workforce practice. And so myself as a professional, I have struggled over the last few years through this idea of research to practice, and what did that really mean? I would say the more you hang out with the researchers, the more you start to get what that really means. We're fortunate that most of them are in the CQI session this morning, so we're going to talk about the real hands-on work. Do I have any researchers in the room? Did a couple sneak in? Okay, they're back in the back, and they're sort of going, oh no, what are they going to do here today? But really, I think thanks to a lot of the work of researchers across the country, and I think their sort of collective peer wisdom to begin to say to those of us that are more in the practice domain, hey, you need to look at this evidence-based stuff. You know, there's something to this. And as they began to have that dialogue and really help us to understand the importance of looking at evidence-based and evidence-informed and how that can be infused across our system. So over the last few years, we've made, I think in child welfare, a lot of strides of at least raising our awareness and beginning to pay attention to this, somewhat behind our colleagues in some of our sister fields like health and mental health and education that apparently already kind of got this stuff earlier than we did. But even if we're slow to adapt, we're starting to adapt, so that's positive. I was recalling, as I shared with my colleague Leslie Rosef, who's part of our panel this morning, a conversation that I had about 7 or 8 years ago with Dean Rick Barth, if any of you know him from the University of Maryland School of Social Work, who's done a lot of work in research and looking at evidence-based practice and how to really make it fit in the child welfare system. A few years ago, when I was the director for the Implementation Center, and we were beginning to take on applications for projects for the implementation centers across the country, he said to me, well, I suppose the states are going to be really applying to the implementation centers so that they can work on projects about building their capacity to implement evidence-based practice. And at the time, I'd kind of heard about this evidence-based practice stuff, but wasn't quite sure, so I politely nodded, as we do to our colleagues in research and academia, and really, said, I don't really think so. I think that, where states are is really, really right now looking at practice models and their PIPs and policy implementation and those kinds of things. I don't know about this evidence-based practice in child welfare. So I'm going to fast forward to today and tell you that, gosh, he was a smart man, right? As we've all come to know. And actually, before I started to prepare for this session, he was one of the people I had a conversation with about where things have gone in the field so far. And I'm aware that in 2008, he published an article, "The Move to Evidence-Based Practice, How Well Does It Fit in Child Welfare," back in 2008. And that was really before most of us were thinking about this. So, you know, kudos to our research colleagues who sort of have raised our awareness about the importance of this. And I think today, what you're going to hear from our panelists is really an understanding of how far the system has come, how the work has become infused in waivers in their particular jurisdictions. And then I think I'm going to call on many of you in the audience to participate in a dialogue about some of what you are learning so far in your implementation of evidence-based practices. So our Q&A session that'll sort of follow the panel will not be so much a typical you asked kind of stump the panelist time. It'll be an opportunity to some degree for us to maybe foray a few questions out to all of you to really sort of mine some of what you all have been learning about these organizational workforce challenges as we look at implementation. So people are going, I didn't know that's what we signed up for today. I'm glad you're all here, and we'll hopefully be engaging you in the discussion. I want to take a minute to introduce our wonderful panelists for today. First of all, Leslie Rosef, who's with me here, a former colleague of mine from the University of Maryland. She's actually still a colleague, but from our days at the University of Maryland. Leslie is a licensed clinical social worker who spent her career in service to children and families in the child welfare system. She's been a practitioner, a program administrator, a consultant around capacity building activities, and particularly has focused a lot of her career on workforce development and organizational improvement. The reason I invited Leslie here today is that she is currently the director for the National Center for Evidence-Based Practice in Child Welfare, which is located at University of Maryland School of Social Work. And I thought she could provide a really good framework for us to be thinking about what implementation looks like and share with us some of the work that's begun to be happening out of the National Center that could help inform our work around the waivers. So welcome, Leslie. I'm going to kind of go across and do all of our panelists before we get started today. Next, we have Carrie Smith, and Carrie comes to us from New York City. I had the pleasure of meeting her, although we've chatted over the phone and on email. Carrie is both, has a law degree as well as a master's degree in social work from the University of Texas, and she is the Associate Commissioner for Performance Measurement, Monitoring, and Improvement within the Division of Policy, Planning and Measurement at New York City's Administration for Children. And in this role, she oversees monitoring of all the foster care and preventive providers and manages system-wide improvement efforts across the city of New York. And in her role with New York City's 4E waiver, which is Strong Families New York City, Carrie leads the coordination of all system-wide implementation planning around the waivers. So we're happy to have her join us today. And she is here with a colleague who I've had the pleasure of talking with a bit over the last couple of months. Ina Mendez is the Acting Assistant Commissioner of the Office of Title IV Implementation and Monitoring at ACS in New York. And in her role, she works on coordination and implementation of Strong Families New York City and Child Success New York City, which are two of the initiatives focusing on utilizing evidence-based practices in foster care. Prior to this, Ina was a senior social worker at the J.E. and Z.B. Butler Child Advocacy Center at Children's Hospital, and in that role, she coordinated parenting skills building and conducted forensic interviews and provided therapy to trauma victims. So she's also an MSW from Howard University. Welcome home. And she has a bachelor's in science in business administration with a concentration in public administration. So welcome to you. And our panelist at the end there is Kim Mann. She goes by Kimberly or Kim, she's told me. And I'm trying to find my notes here, excuse me. So Kim is Dr. Mann. She's an associate professor of social work at Chicago State University And she's currently the project director for the Illinois Birth to 3 Title IV waiver with the Illinois Department of Children and Family Services. She's had work across her career in program development and research as well as clinical practice. She has 25 years experience in the field, and has also served in a consulting role to community-based organizations, particularly around serving young children with families that have been exposed to violence. So, a wonderful panel we've got going today, and I'm going to invite Leslie Rosef to kick us off this morning. Leslie?
Thanks, Kathy. Good morning, everyone. It's nice to be here. So I want to start us off by when I found this, I loved it. I thought, isn't that nice? It's a beautiful distillation of the work that we do in implementation at the practitioner level, what needs to happen at the organizational level, and at the systemic level. And I thought, it just sums it all up in such a nice, succinct way. If only it were that simple, right? Because as we know, it's much more complex. It's multifaceted, there are many nuances, it's not that straightforward. So what we'll be talking about today, and particularly what I'll be speaking to, is more setting that context, talking a little bit about some of the context, mechanisms and processes and outcomes at these different levels that one needs to consider when you're doing EBP implementation, and then you'll be hearing from the rest of the panelists about their particular experiences in their jurisdictions. So as Kathy mentioned, one of the things that we know is that it really is relatively new in the field of child welfare in terms of EBP implementation. And so this slide just represents some of the research. And as you can see, there's a huge spike that's just happened in the last 10 years. So it is relatively new for us, but it's exciting to see how much work is being done. And many of you have probably participated with your research colleagues and writing some of these journal articles. So that was just really interesting to see how much is really happening in this field. So I wanted to also just reference that much of what we'll be talking about today is certainly grounded in general implementation frameworks, and so I've just included a couple here that you are most likely familiar with. One that you may not be as familiar with that I would encourage people to look at is the Global Implementation Initiative. And that website has resources from around the world. So it's really interesting to compare and to contrast, see what's happening in the UK and Australia and in Asia. So there are many, many resources out there that people can draw upon. So you have a handout of this. And there's also on the flash drive, in addition to the PowerPoint, there's a visual depiction of the next two slides, and there's a front and back on this handout, as well as a bibliography of some of the seminal articles related to evidence-based practice implementation in child welfare and in children's behavioral health systems. And I'm showing you this just to highlight I'm breaking all of the rules with PowerPoint in terms of you can't read it. That's why I made sure that you had a handout in front of you to be able to see it. But I selected these next two slides really to help people see it really is multifaceted. There are many, many considerations that go into evidence-based practice implementation. And what this represents is, it's from an article called Innovation Adoption, a Review of Theories and Constructs. And what they did, I'm not recommending necessarily reading this article, it's pretty heady. It was probably written by a grad student, also includes Kimberly Hoagwood, contributing author to it. But so it includes a summary of 20 different theoretical constructs and models. So this is distilled into this very complicated graphic, but really it's setting on the far left, looking at the context which you need to consider for innovation and implementation. So we'll be talking about, at the systemic level, the organizational, and the individual levels. And then the mechanisms or processes that we'll be going through a lot of these in the next hour or so. And then what are the outcomes that people hope to see as a result? And then this is a model, the dynamic model of a dynamic adaptation process that Greg Ahrens and his colleagues came up with that overlays the phases of implementation along with an evidence-based practice. So again, very similar components where you're looking at what are some of the system level impacts that need to be considered. It's also looking at the resources, and outcomes that are required. And so we'll spend a lot of time talking about some of the activities that happen in the exploration and preparation phase, and then as well as Carrie and Ina, New York has been doing a lot of EBP work for a number of years now, and so they're further along and looking at some of the sustainment and scaling up activities. So I love this because I think, when you think about embarking on some of these bigger system improvement, EBP implementation, it's exciting. Some of us really like that new challenge and get excited, but it also entails taking a risk. And sometimes we got to take those risks and help our colleagues come along with us as we embark on these activities. So in terms of thinking about the environment and context, I'm going to kind of walk us through each of the levels, starting with at the system level. And these are really questions that the what and how questions that systems really and organizations need to be thinking about. And Kathy had said, you've already spent a lot of time looking at the selection, but there's so many other considerations that people need to be thinking about, and this takes a long time. Carrie's going to talk about, way more than you would anticipate, as some of you have probably encountered. So you think, okay, we've identified our evidence-based practice and we're ready to implement, but there's so many things that really need to happen before you get to that point. So really looking at the system level, an examination of your current funding and policies and what needs to change and at what points in time to accommodate evidence-based practices. So related to contractual mechanisms, do you need, and so let me back up for a second. One of the things that as I'm speaking, I'm thinking about and speaking to evidence-based practices that the child welfare system workforce is implementing. It could be safe care, things like solution-based casework, but also evidence-based practices that your partnering mental health systems or agencies are delivering. So when I'm talking about workforce, it's really both. So with contractual mechanisms, it's a little bit different because if it's a child welfare intervention, if they're the interventionist, then you wouldn't necessarily be looking at contracts, but it's certainly a consideration if you're looking at partnering with a community-based mental health provider to do that. So do you need a formal request for information from them? Do you need to issue a formal RFP? So looking at those questions and then building in time for that, because that takes a lot of time to be able to create that information, send it out, review it, and select your providers. So in terms of thinking about political changes and influences, usually you've got that leadership buy-in and top-level support, but as we know, there's lots of changes in administration, and in fact, the National Center, we're currently working with 4 jurisdictions across the country, and in less than a year, the top 3 of the 4 organizations have had significant changes in leadership. The plus side is we've been able to keep going forward because there was buy-in across the agency at all levels. So the project continued to go forward. So that's certainly making sure that if things happen with a change in leadership, that you're able to sustain your project. Looking at the organization and agency level, really wanting to examine what do the current communication channels look like. Typically, it's a top-down where you're issuing policies, so really examining what are our current feedback loops, what do we need to put in place to make sure as we're rolling this out that we're hearing from all levels and that it goes up and down and sideways and that there are really strong feedback loops. Also, really examining the fit within your existing service array and, what do you have currently going on? What are the organizational values and cultures related to evidence-based practices? How is this evidence-based practice that you've selected going to fit in with that? How will it be received? Looking at the leadership support for that, and not only they have the buy-in, but what mechanisms, what activities are they going to do to engage their staff to create that buy-in for folks? And then, I'm sorry, trying to see back here. What are the resources that are needed? And really taking a look and not assuming anything. And I have IT on here as an example because I think we assume that when we go to implement any new practice that you have some of those basic resources such as computers. And what we're finding is some agencies literally did not have PCs. And so part of our evidence-based practice requires clinicians to go to a web-based site and enter information on their clients. And they said, well, how are we gonna do that because we don't have our computers yet? So, not assuming anything, really talking with folks about what do you have, what do you need, who's going to do what, and really examining all of that before you implement.
That's mine if you.
Oh, Carrie's is a little bit bigger, mine is shrunk. And then looking at the organizational culture and values and what are the attitudes at the supervisory level, at the worker level in terms of evidence-based practices. So really asking and examining what is the current experience with evidence-based practices. Not that people have to have a lot of experience, and in many agencies you're coming in and you may have a couple therapists trained, or if it's a child welfare system, it may be a brand new practice, but really finding out ahead of time what are people's attitudes towards that? What's their background and experience? It doesn't mean that they have to have a master's or PhD to do this, but it really you need to understand what is their individual value and belief around evidence-based practices. What's their theoretical framework? If they're coming from a background where it's much more psychodynamically oriented, it's going to be a bigger stretch for them to take on some of these new practices. So just being open to asking those questions and really kind of exploring that ahead of time, and then coming up with strategies to address that. So really, you want to be able to look at what is the agency currently doing around training and coaching and supporting their staff, what else needs to be put in place to ensure that this is going to stick. When you think about bringing in an evidence-based practice, there's usually a lot of initial support, and people go through formal training and they get coached, and then there's turnover. And we see this a lot, almost immediately after following the formal intervention, people resign. So it could be the supervisor, it could be the direct frontline practitioner, and so then what? You're not scheduled necessarily to bring back, or you haven't done a train the trainer. So, what mechanisms will you have in place in that gap before you're able to do formal training to ensure that people coming into the agency are able to understand and not feel like they're left out until the next round comes around. The other piece you need to be thinking about is how will you ensure that there's fidelity to the model, and that really is happening at all levels. So, what's our CQI system going to look like? What's the role of the supervisor in that? It's happening at multiple levels, multiple times to ensure that there isn't the drift. So switching over, so those are some of the what and how. And that really, as I said before, takes months and months to really unpack that. And there's a lot more components to that. Those are just some highlights. But switching over to facilitators and strategies to build capacity, at the system level, you really want to think about incentivizing broad use of EBPs and aligning the policy and the funding mechanisms. If you're working with mental health partners, that mental health, as Sheila was talking about this morning, making sure that your Medicaid, your mental health, your child welfare, that the funding and the policy is in alignment. The partnering with developers is really, really important in terms of that takes time, and Carrie and Ina and Kimberly, I'm sure, as you are well aware of, there's many different models, and some have much more adaptability and flexibility than others. Some are very proprietary, and the developers will remain with you for the duration. Others, it may be building more local capacity, and so you want to really be able at the front end to partner with the developers, to understand and ask those questions about, is your model something that we can replicate? How long will you be involved? What is all of that training, timeframes and resources required? How much adaptability and flexibility do we have as a system to be able to take this model and modify it to our needs? And so some of the things are core components of an EBP, and you can't change those. But others, in New York, for example, has taken some of the components from our model, which is Partnering for Success, and there's a flyer on your table, and they really upped the bar in terms of the expectations. And we had some set criteria for the number of calls and supervisory support that we provided, and they said, well, we want more. So, then you have that flexibility. So, it's really working in partnership with developers around what it is that they require and what it is that you'd like to see as well. So in terms of, selecting organizations and agencies with demonstrated readiness, that's a big catchphrase. Readiness is very important. So what does that really mean? Because there's varying degrees of that, as we've learned in our work. And so I think one of the important key things with that is really being able to talk to all levels of the organization. Certainly when your leadership buys in, or they wouldn't have adopted this new practice. But really you need to be able to have systems in place and forums where you can talk to the workforce. So for example, with our agency, as we're considering working, our center working with agencies, we have a call and we say we want at least 2 frontline practitioners, a couple of supervisors, a mid-level manager, and then your executive director. Because we really want to be able to hear from them, what does it look like? What are you currently doing? What are your resources and capacity? How are you feeling about this? What scares you? What excites you about that? So really making sure that you're able to assess that and to hear from folks at all levels. And then, I can't see behind Kathy, setting a high but realistic bar. So when you think about those outcomes, and because this is a 4E waiver convening, you're really tying it to those federal outcomes of safety, permanency, and well-being. When you think about an evidence-based practice, what I mean by setting a high but realistic bar, some of the EBPs are really focused more on safety, safe care, as an example. Some are more focused on improving the mental health outcomes of children, youth, and families. And so that's more geared towards well-being. So being realistic when you set your outcomes, that the EBP is really going to achieve, that intervention is going to achieve the outcome, and not have it be more of a stretch than you really, don't want to set yourself up for that. So at the organization and agency level, really ensuring that, we've talked about having strong administrative support and identifying champions early on. The administration really needs to prioritize it and allocate sufficient staffing and resources to support that. And I think that a lot of times there is that buy-in at that top level, but then the leadership may not hold organization-wide meetings and really communicate and hearing back from staff about what it is that they need. So it really you need to have that input from all levels in the organization. And really making sure that you are setting up practices and policies so that it's fully integrated into your program. And so some of the agencies that we see, it's one component and maybe one of many evidence-based practices. And so we talked about how does it fit within that service array for people to see, yes, it does fit in, it's here to stay, and there will be the resources for that. Other organizations have decided we're going to adopt one evidence-based practice, and that will be the model for a whole agency. Sometimes that's easier for an agency because they're not competing, and the staff can really delve deep in terms of their understanding and application of all of the components of the model. But making sure that
that it's really integrated into the policies and the practices. One of the things that has come up and been really key with that is referrals, and ensuring that you have, once you've selected your evidence-based practice, do you have enough clients that meet the inclusionary criteria so that you can be able to serve? So that we found is absolutely key, and so you want to make sure that you don't necessarily want to change a child who's receiving services from another provider to one that's being trained in your specific evidence-based practices, so you have to take those things into consideration. But then you also need to make sure that you have a really streamlined and clear referral process so that the kids that are identified and screened can be able to get referred to the agency. And that seems pretty straightforward, but we found that it's actually much more complicated than that. We've also know that monitoring and using a quality improvement process is really key, and that data is really important and should really drive all of your assessment of how things are going, and being able to hear from the field about what's going on, and being open to hearing what the challenges are. So it goes back to those communication mechanisms. So it's not really done by your CQI staff in isolation, but that you're eliciting information from your practitioners, that you are feeding back information to them about what's working, what's not, and being able to make adjustments as needed. And then the implementation teams, we haven't talked much about that. Again, making sure that you have implementation teams that are representative of all levels of the organization and the different disciplines across the organization. So with our projects, we've made sure that we do have frontline practitioners, that we have supervisors, we have IT people, we have the intake folks, so it's very well-rounded and representative, and not just heavy on leadership, because we really want to hear from the folks that are doing the work. What are your challenges? What are your barriers? What ideas do you have that we could incorporate in terms of solutions for moving forward? And then related to the frontline practitioners, workers and supervisors, really making sure that you are layering supporting activities over an extended period of time. And by layering, I mean thinking about that transfer of learning, the bridging, the training to the practice in the field. And so doing a lot of pre-work to really ensure that people understand, creating that buy-in, that they have support, ongoing application support through supervision and coaching. And this could happen anywhere from 3 to 6 to 9 months in a very formal and structured way. And then we really want to build the capacity of the supervisors as well as the organizations to understand the practice so that they can continue that over time. We also want to make sure that you're hearing from the workforce, what are their experiences, big and little, and not to underestimate that some of those little things can get in the way of making big changes. And so we definitely want to hear from folks about how things are going. And again, related to the communication and feedback loops, making sure that the suggestions that are made from the frontline workforce get incorporated. Carrie and Ina will talk about some of the challenges and solutions that New York City has come up with related that have been huge lessons learned and very helpful going forward. So I'll just leave you with this and transition over. EBP implementation is a process. I was talking with a colleague about thinking of it as a slinky. So for those of you, I almost brought one. So, you get in the groove and you really feel like things are moving along, and, you're playing with your slinky. Sometimes you can pull the slinky out, snaps back and bites you. That's not so pleasant. But then when you really get into momentum and that slinky is going down the stairs, that's the ultimate, right? And so EBP implementation is like that. You're going to go forward, you're going to go back, but ultimately you hope to be able to have that slinky go down the stairs. So I'll hand it over to Gary.
Great.
So we're really excited to be here and be part of this panel. We first want to thank New York State. New York City is part of the New York State waiver, and through our piece of the waiver project, we're implementing 4 initiatives to evidence-based components, which is CBT Plus in the framework of Partnering for Success and Attachment Biobehavioral Catch-up. In addition, we're reducing caseloads and implementing CANS New York. So what we wanted to do today is just give a brief overview of our experience implementing EBMs generally, because we've learned a lot from our previous implementation of EBMs that we're bringing to our 4E waiver work now. And we are continuously learning ourselves, and it's really interesting. Every stage of implementation, we learn more and more, and we're able to apply it to new experiences when we're implementing new models in other areas of our work. So we look forward to this discussion. To just start, we started by framing what our goals and objectives were for implementing evidence-based models in child welfare in New York City. And we specifically stated that our goal was to provide services for our children and families that will support the greatest likelihood of positive outcomes. And we're going to do this by adapting existing national models and developing new ones. And so what that meant for juvenile justice, it means that we were continuing on with some evidence-based models that we had already been using in preventive services related to juvenile justice and prevention of detention and placement. And then also looking at new residential care and aftercare services. So recently New York City took on non-secure placement and a limited secure placement, looking at evidence-based models in residential settings and what that means. In the preventive field, in about 2011, we started looking at what models in preventive juvenile justice that could we adapt to use in child welfare. And we brought over several models that ACS was using in juvenile justice into the preventive services arena that was focused mostly on teenagers and working with teens. In addition, we recognized that we needed models that also worked with younger children, and so we brought in several 0 to 3 models, Safe Care and CPP, and also some other evidence-based models that had a wider range of target audiences. And so in that time, annually we serve about 56,000 preventive families a year, and we've now, over the course of the last 3 years, transitioned to have 30% of our preventive service EBM models. And so later on in the presentation, you'll see a graphic of all the different models that we're using right now in New York City in preventive foster care. But it's been a really exciting journey transitioning in just a short time to have 30% of our system using EBMs. And we've learned a lot from that experience. In foster care, we have been working with evidence-based models for several years now, starting with MTFC, now TFCO, in therapeutic foster care, and then doing a pilot with 5 of our foster care agencies we call Child Success New York City, using KEEP and PTC in regular family foster care, and have gotten some great preliminary outcome data using those models. So we're really excited to continue that work and learned a lot around implementing evidence-based models in foster care in those experiences. And now with Strong Families New York City, we're implementing Partnering for Success with 18 foster care agencies, and Attachment Biobehavioral Catch-up, which will be available to all of our 23 foster care agencies over the next 3 years. And so we're really excited to be able to build on kind of our experiences so far with evidence-based models, and happy to share some of the experiences and learn from all of you as we talk today. So we had specific reasons for implementing evidence-based models. We wanted to shift the focus to outcomes and really move the conversation away from kind of anecdotal practice successes to really looking at the data to identify what's working and what are getting the outcomes that we're really looking for. We really wanted to identify models that were better tailored to fit the needs of our families that we were serving, so that required us to do needs assessments in an ongoing way and identify which models might fit the best need. Because we have a large system, we have the flexibility of having a continuum of services. So there's variety available to meet the diverse needs of New York City families. And we've learned, and through experience, we identify which models have been working better and which models aren't working as well as we had hoped, and we can make adjustments as we go to really continue to meet the needs of our population. Another real interest of New York City's was to bring models that had a consistent approach to practice and supervision. The goal was to use the models to strengthen the capacity of our workforce and build skill. And so in New York City and perhaps in child welfare across the nation, there's varying levels of education and experience that come from your frontline staff, and so and limited resources for training on foster care and preventive side. We have a more comprehensive training for our child protective staff, but less training resources in New York City previously for our foster care and preventive. We're currently building up a new workforce institute that we're really excited about to change that, but in the past it's really been a struggle. And so evidence-based models brought really structured training, additional clarity around the role of the supervisor in supporting the frontline worker, and additional support from an evidence-based model consultant oftentimes in developing skills and capacity in the new model and the new skills. So that was something that we were really looking for and was part of our selection process. And what we were also hoping is that, and our intention was for the models to provide additional skills and support to the worker with the hope that that would reduce turnover. And we know, kind of working in this field, the challenge of the day-to-day work and how support can mean so much, and also feeling rewarding and like you're really accomplishing something, and as a professional you're building your skills and really taking a clinical focus in a lot of the work you're doing is appealing to a lot of staff. And so it was an opportunity for child welfare professionals to gain additional skills and feel more supported and hopefully reduce turnover. Multitasking. The common features of EBPs that we selected were that they were primarily in-home services. And so we really wanted to shift practice from having families come to the office to going to the family's home and making it about the family practice. And so that was a major motivator in our selection process. In addition, we really wanted to make sure all of the models were family-focused and had a community-focused approach. So cultural competence, but in addition, really identifying kind of what the family makeup was and bringing them into the treatment. So a lot of the models are family therapy based, so it's not just one primary target, but it's really talking about the family component. Another real important factor for us were that most of the models that we selected, I believe almost all of them, are manualized. So it's really setting clear expectations, and it's really helping everybody understand what the practice is and what you must do. And with a significantly high turnover rate in child welfare staff, really having that structure is really important because you're continuously re-educating a new workforce. And so having that program manualized helps you do that, and helps you do that in a consistent, high-quality way. Where there weren't manualized programs, we created manuals. And so we worked with the developer to develop manuals for policies that were ACS specific. And some of our stronger models, the manual process was actually a collaborative process. And so the developer came to New York City, and we together looked at our ACS policies and practice standards and integrated them into the manuals so that they were aligned. That was really important when we were talking about models where the caseworker became the interventionist, and the intervention wasn't necessarily a safety and risk intervention. It was more around a clinical intervention for mental health treatment. We had to integrate the safety and risk responsibilities of the caseworker into that practice of the interventionist, because it was the same person doing that work. And so that was a lot of effort and time and energy and ongoing work that we do, especially on the preventive side, where there's a dual role of the caseworker to be the interventionist and also the caseworker and case manager. We hoped that kind of by integrating these practices into the child welfare work, it would be experienced by the family as a more comprehensive treatment, that rather than referring out to multiple different service providers, you could really get that the core services that you need for your for reunification or for permanency or for stability from the caseworker directly. And that was really the goal in trying to get as many services as we can integrated into our preventive and foster care continuum. We looked for strengths-based and short lengths of service. And as we did our research and as we learned more and more about kind of evidence and what the evidence base was showing us, it was showing us that longer lengths of stay do not equate to better outcomes. And so the models that we identified reflected, concrete timeframes for service delivery that would achieve those outcomes, and had the evidence behind them to support that. in addition, shorter lengths of service also helped us identify kind of capacity and funding. So we can talk more about that later. So the more families one caseworker can see over the annual year means more families served, whereas before in general preventive, for example, a family was in services for approximately 1 year. Most of our evidence-based models in preventive services now are anywhere from about 4 to 6 months of service. And so that's just a shift, so we're able to see twice as many families with that one social worker than we were before. So smaller, more reasonable caseloads for both the caseworker and the supervisor are part of almost every EBM we implemented, and quality assurance through fidelity monitoring was built in. And one of the pieces of work that we're still working on right now that we can talk about later is integrating fidelity monitoring into our quality assurance monitoring as ACS, and so that's an ongoing process. But having additional quality assurances through fidelity monitoring by the developer was a real appeal to us in implementation and selection. So just quickly, this is a slide that represents all the different models that New York City is using, evidence-based models. To the left, it's the preventive, and it kind of goes from least intensive to more intensive. And then in foster care, you can see the lower is regular family foster care, and the two higher are therapeutic foster care. And so we've really had the opportunity to work with a lot of different developers, and seen a variety of different kind of implementation plans that developers bring to the table, and models and resources that each developer has. And it's taken us a while to really identify kind of what New York City wants from every developer and every model, and how to partner with developers to meet our needs when they're coming to New York City with different packets, different models, and what they can provide and how many resources they have to support the work. And we'll talk a lot about how we've really formed really strong working relationships with all the developers and have ongoing communications. So that's been a big part of our implementation process. Do you want me to do it?
Okay. So, hi, good morning. So as Carrie laid out, we did have a very comprehensive and aggressive plan to introduce evidence-based practice to our child welfare continuum. So in our early stages, we recognized that many of our ACS staff, our Administration for Children staff, and also the providers we worked with had limited knowledge about what evidence-based practice meant and how that was going to change how they currently provided services. So we had a lot of forums, we shared a lot of information, and really started to have different focus groups and task teams so that they could understand what evidence-based practice was, even prior to starting the actual implementation. We had opportunities for developers to come and share different programs, so agency administrators and foster care providers and preventive providers could learn about the models and ask questions and kind of gain their understanding, so they could begin to think about what types of models they wanted to implement. We also noticed that we had a limited ability to do internal training and support training and technical assistance. So in the last year, we've really ramped up on our workforce development and the ability to provide training in-house and also with our foster care providers. In terms of policy practice alignment, we had to do a lot, and Carrie mentioned this, a lot of work with the developers and our current policies on how things maybe don't match and what we could do to assist the providers so that they were not out of compliance with the policies, but that the policies better supported the actual implementation of the model. So we did a lot of reviewing and work to make that more cohesive. And then there were also a few occasions where there was some misalignment with some of the child welfare policies and the EBM practices, particularly around safety and risks. For instance, some of the models may have initially focused on one particular child. We have an expectation that if a case planner is visiting a home, they'll pay attention to all the children in the home, not just that one particular child participating in the intervention. So we had to do work to adapt the practice so that it would stay in alignment with our current policies. And then there were some areas where we had to look at some model adherence activities and also things for evaluation so that we could continue to effectively monitor. So we often get reports from model developers. The agencies will get their reports on model fidelity, but we will also get an aggregate report so we can assess how agencies are doing with their model fidelity and step in and try to support their work so that they can deliver the models with fidelity. What helped us a lot early on was we began working with Dr. Allison Metz of the National Implementation Science Research Network, and she was able, using an implementation science framework, to come in and support and do a lot of assessing of our strengths and where we had needs in terms of what issues we'd like to address through evidence-based practice, but then where do we fall short in moving forward with this. And she did a lot of stakeholder forums, data mining, data analysis, and she really helped us pinpoint where we should focus our energies and how we can move to meet our particular goals. So that was a lot of work, and she did support us in all these areas of capacity building, policy practice alignment, and evaluation and monitoring. And then as we're currently implementing our waiver interventions and the other models that Carrie described, we are looking to the future and how we're going to sustain these models, and we're thinking about ways to make sure that this is truly integrated in practice, and ways that the agencies continue to develop their own capacity, either to monitor themselves or to provide training on site. Okay. So lessons learned. I think the biggest takeaway that I have is that it's important to look at what the lessons you did learn over time, and how you started out might not be how where you want to be. You have to always make those changes. So giving everyone an opportunity to talk about what they've learned and making some changes as you're going through was important. It's also important not to underestimate how much planning is involved and how much communication is necessary to move these initiatives along. And that needs to happen prior to implementation and while you're implementing. Merging ACS and model developer evaluation and monitoring efforts, we did a lot of work to make sure that our program development areas and our monitoring areas work together so that they understood the models, but more importantly, understood how best to support and monitor the agencies in delivering those services. And that we recognize that sufficient funding is important, and also that we need to give a message that these EBM practices are critical to the goals that Carrie outlined earlier, and also not an addition to the work, but this is actually now the work that we're going to be doing. Okay, I think that's my 2 minutes. Big.
There we go. Hello, everyone. It's scary to bring up the rear. I'm here to talk a little bit about our efforts in Illinois with our what we call IB3, our Birth Through 3 waiver. We serve the little ones between the ages of birth through their end of their 3rd birthday, or before their 4th birthday. We are at the beginning of year 3, so we are officially a toddler. We are walking. We fall down sometimes, and we bump into things quite often. And so we're here to just share some of those challenges about our process as it relates to implementation. We came into the waiver really at a very good place in our state as it relates to trauma-informed practices. We had spent some years developing our capacity in those areas. We had piloted various evidence-based interventions, and we were just good to go. We started in July 1st of 13, and we targeted the population of 0 through 3 because of our permanency rates. With like many of our states, we have one of the largest numbers of kids coming into care are under the age of 5. But our permanency rates in Illinois are very, very low. Our length of stay is very, very long. We don't bring in many kids, but we keep them for a long time once we get them. And so we targeted this population, and we began in Cook County, which is the Chicagoland area, because even for our state, our county, had some significantly lower rates of permanence. And so that was our focal group for our effort. We had in place a integrated assessment program throughout the state, and we were able to enhance that to look at the trauma experiences of infants and toddlers and their families. And we were able to really hone in on some of the symptoms that we see in very young little ones as they play out in those regulatory type things of sleeping and eating, et cetera. And really then decide from those assessments what level of service we were going to target for those children. We use a randomized control, and the agencies that we have in the Chicagoland area, in the Cook County region, were designated as either intervention or control agencies. And we have been finding that we have a pretty good split. About 51% of kids are falling into our intervention group and about 49% into our control group. The interventions that we selected were very developmentally informed, very trauma-informed interventions. We had a long history with child-parent psychotherapy in Illinois. It had been piloted originally in 2004. And it's an intervention for those of you who are looking at it or already utilizing it. You may know that both the training process, which is about 18 months, is very extensive. And the use of the model as well, unlike my colleagues who are talking about short-term models, this is an intervention that's typically 12 to 18 months, and so it tends to target those what we call second-order changes, those deeper changes in children and families, and we tend to funnel our kids that are in that high-risk group to this particular intervention. We also, by the way, let me just say, for CPP, we actually had trainers, several national trainers for the model are in Cook County, and 2 of them were even at the agencies that are providers of service. And so, again, starting off at a real strong place for that particular intervention. We also, new to our system was the Nurturing Parenting Program, and like many of our colleagues, we were very concerned about the state of parent education, the quality that we saw, the variable kinds of outcomes that we saw. And so this particular model, which has been around for decades, literally, was very attractive to us for its outcomes. My colleagues have been talking about the collaborations with developers, and we certainly found Dr. B to be a very lovely collaborator for those of you already working with him. And so we targeted that particular intervention originally to our moderate risk and our low risk children and families. I'm going to talk more about that in just a second. But we found that over time, it began to serve all populations, and I'll share with you why that occurred. So currently, as it relates to those levels of risk that I was talking about, and we use a combination of looking at trauma experiences for the children and their families through the CANS, and also some of those enhanced assessments, specifically the infant toddler symptom checklist and the DECA, along with the PSI, to look at symptoms. And we found that our rate of kids in what we call our high-risk category was much higher than we had projected. In fact, for this past fiscal year, it was around 68% of the population. So what we're seeing there is really, very little ones who'd had really, really difficult starts. And that in and of itself for us represents a challenge, a paradigm shift that we are continuing to just tackle on a daily basis. In spite of the great work that we've done on becoming more trauma-informed, how people think about the impact on very small children, we still have a ways to go. So we actually focused a great deal on, in the design of this intervention, we really wanted to support our foster caregivers in a different way than we had been. There was a real commitment to that from our leadership, particularly Dr. Tate, who couldn't be with us today, but that was really a very strong motivation for her, because they're the ones who are providing this first relationship experience, during the times that our children are in care. And so they were targeted or incorporated into the intervention, not targeted, although some of them felt that way at times. But in the assessments, they underwent a parenting stress index along with the birth parents. Just look at the levels of stress that they were experiencing as it related to the care of a specific child that that we were focused on. That in and of itself was the first of those challenges, that intention of supporting foster caregivers and the realities of how that got experienced in a system that typically was recruiting and monitoring them, but offering less support to them. So I'll talk a little bit more about that as we go forward. In terms of, what we were thinking about as it related to the evidence-based interventions, like all of us, we've talked a little bit about the issues of selection. We certainly found implementation science to be extremely important to us in our considerations of models, in our original interviews with developers and such. But we also thought a great deal about this issue of sustainability as well, and my colleagues have already talked about those issues. We were very interested in trying to find ways that we could build internal capacity. We would see that turnover of staff. You train these amazing clinicians in these models, and you find that you need to continue to bring in new people and maintain that capacity over time. What we felt like we really spent a great deal of time on, and where I'm going to be focusing my brief comments now, is really on the interface between the model and the field, specifically the casework role in these mental health models. And that, for us, has been a very significant, and it continues to be a very significant focus of our work. So one of our lessons I'm going to share on the front end here is that the interface between the model and everybody else, the courts, the caseworker, quality assurance, all these different places, is really where we're probably as a field going to need to really consider in much more significant ways, how we make that happen. Because as we believe, and we've said before in these meetings, it's much more than training. We all know that, right? That's not sufficient. So let's just take a look at what that looked like for us. When we think about this intensive interface, working intensively around this interface, we did a ton of things, and many of them well. We of course did training to help the field understand what it was we were trying to do. We created brochures. We created a video, which I wish I could show you. We have summits annually and bring everyone together to tackle these issues together. But where the effort increasingly is becoming more and more and more important, and where we're adding efforts literally year by year to accomplish the work, is really at that level of technical assistance, field support, between, at the level of individual cases. And so when we're trying to get the folks on the intervention side, they clearly have to have a strong understanding of the context of child welfare. All of our providers are coming to us from the child welfare system. They are the clinical divisions of child welfare agencies, and their buy-in to evidence-based practices was high. They understood things like, what the core competencies of a model was going to be. That was very clear for them. They understood the issues of, how we think about trauma and how these models were specifically going to tackle that. But the broader system is where the effort, is really so critical in helping them to come along in those same kinds of ways. So when you think about things like testimony of a caseworker, that notion of how to understand, where they're testifying about progress and how we move along, and not just thinking about progress as attendance and progress as they went to the service, but really that we're seeing movement over time around these core competencies of these models. The same thing is true for the courts and helping them to understand the things that we were trying to do. And then, again, those foster parents. For them, the level of participation that we were asking in both of these interventions was much higher than we had traditionally done as a system. So for child parent psychotherapy, we found most of our foster parents were the original dyad that was being seen, because oftentimes the birth parent may not be ready when we were initially making those CPP referrals. And so getting them to understand that not only were they going to participate, not just bring the child to service, but participate in the service, in a baby service where they might have to get on the floor and play and all of that, really a big shock to the system that we're continuing to have to give some consideration to. And so my colleague who's here with me today will recognize her words here. So the challenge then that we found ourselves dealing with is that some folks thought these were the easy cases. I get that from Sherry. And the reason she said that was because, you know, if you've got a caseload that has folks of all developmental ages and stages, and you've got 16-year-olds running away or involved with juvenile delinquency, that 2-year-old looks like, you know, a piece of cake, except when they get kicked out of daycare and tear things up, and, you know, but the little ones, you know, are much easier, big air quotes there. And so what we're finding is that when we think about this interface between the model, and I'm using only our CPP as the example that I'm trying to create here, but we could do it for both parts of our interventions. But when we think about what they're trying to have happen, we start off with this issue of need. And again, you've got your CPP folks who clearly get, you know, why this baby is there, why, you know, what are the trauma issues that brought that baby. But I'm going to just share a little bit of an example. We had a case that we use as our training case of a little one who actually started and engaged in CPP. And at some point in time, I got a call that they had been pulled out because the caseworker had questions. And so I met with that caseworker because, as you said, I'm a university person. She was one of my former students, and so she got called to the teacher's office. And so I asked what had happened, you know, why the baby had been pulled from treatment, and she said, well, I didn't really know what this was. We'd had trainings. I told you about the brochures and the video. I told you we did all that stuff, but she didn't really know what this thing was. And her biggest issue was she's too little. She's too young. She had traumatic brain injury, horrible trauma in the first 6 weeks of life, but she's only now 3 months old. She doesn't remember that stuff, right? Please don't anyone nod at that. And so once I started to talk to her about the symptoms with babies and sleeping and eating and all that, she goes, oh my God, she remembers that? She's our poster child now. She's actually being adopted, so her permanency is being finalized in the next couple of weeks, and she went back to the therapy, by the way, and that person became a champion for the work. But again, understanding the need, understanding how she could support engagement, how she could work with that foster parent who had questions, and to help her not just to say, what is this thing, but to be able to respond in a way that supported the engagement of that foster parent who now will become the adoptive parent for that particular little one. In terms of monitoring, we think so much about getting our kids into these services, but not as much about the role that the caseworker can provide in terms of supporting the ongoing engagement, and that's another area where we want to continue to focus our efforts as well. And so when we think about this issue of communication and coordination, the roles of each of these players, I think we're facing a new challenge as it relates to even on the side of developers. There are some models that really do take that whole system approach. TSTSI you guys were using is one of those that I think about. But we've got to start to think about really being really specific from the level of the academy to training, pre-service training, to ongoing implementation of these evidence-based models, into how we're going to make these roles all fit together. And that the critical role, particularly that our field staff, our caseworkers in particular, are playing in supporting this practice. And we've got tremendous challenges to think about as we do that. We haven't quite figured them all out, but we'll be for next year, so we'll be hopeful. Thanks.
Great. I want to ask everybody to give our panelists a round of applause. So, as I said when I opened up the session this morning, our Q&A session will be a little bit different, as it's standing between you and lunch, so it's all about your participation. So, I want to start off with kind of throwing out a question, and the question really is both to the panel and the audience. We have a couple of mic runners. Raise your hand. There they are, James and Mary from the Capacity Building Center. And so what I'm really looking for is knowing that there's a wealth of information in this audience as well. We tapped a few experts to come in and be part of the panel, but we know there are experts in the audience as well. So I would encourage you to sort of provide your wisdom to the group and share your wisdom with your peers on a couple of these questions. A few areas that I think were sort of touched upon by the panel that are worthy of a deeper dive, so to speak. And one is this question of aligning evidence-based practice with child welfare practice in general. And our panelists touched on that a little bit, how they were doing that, what some of their strategies were. I'm wondering, I'm going to start with throwing this out to the room. Thinking about your work already on the waivers and evidence-based practice, what are a few of the strategies, or at least one strategy, that you may have used in order to begin from the beginning of aligning your evidence-based practice with your child welfare practice? I think our panelists talked about work with caseworkers in courts, et cetera, in a way that the FIT's going to actually work as across implementation. Anybody want to share their thoughts about how they may have begun to do that a little bit? Again, sometimes it's a rough fit from the beginning. Thoughts in the room? And a hush falls over the crowd. Yes.
I think it was important for us when we implemented our MST and intensive home-based therapy with our social workers. Many of those folks who do frontline work on a daily basis see it as one more task, one more piece of paper, one more document, one more way for you to wreck my evaluation because I didn't do it exactly the way the evidence-based practice required me to. But I think what was critical for us is showing them that the data actually works for families. And families didn't come back who experienced MST. And the buy-in from staff and obviously having them participate with the family and basically celebrate those successes. Not only from, like you guys have talked about, a management level staff, but in their management meetings, in their with their supervisors, sharing the success of implementing this and being able to explain how the data works on a daily basis. So it's important for them to understand that it's critical and it's successful for both the family and the kids. Because if you don't have their buy-in, it fades away and it's just a struggle, a day-to-day struggle for them.
Great, thank you. And I'm sorry, you're from what state?
I'm from Ohio.
Ohio, the great state of Ohio. Thank you for sharing that. Anybody else want to sort of weigh in on this question of the fitting in the system? Our good colleague from Missouri, Tim Decker.
Thank you. I think, and I've been thinking this as a presentation's been going on, and I think Carrie talked about it a little bit, but I think it's incumbent upon us as child welfare agencies to begin with underpinning values that are really important to us that become the tie that binds all these things together. And I think any developer that we work with has to subscribe to those values and also has to be willing to talk to the other developers we're working with so we have really aligned the practices. So technically I tend to, and we tend to shy away from developers who only want to do their program and aren't open to adaptation or integration or alignment with other providers. The other thing that we have found to be really important along alignment is looking for practices that actually have the potential for parallel process throughout the organization. So where you have practices that can also drive a little bit how you talk with your staff, how your staff talk with your leaders, so that we're not just working with the families. In fact, we operate from the philosophy that how you're working with your staff is how they're going to work with their families. So models that really only prescribe the practice with families and don't have adaptability throughout the system so that we can all kind of model those approaches and model those values that tie those all together are models that we tend to shy away from. So we've got 3 different developers we're working with, and we're actually requiring them to actually talk to each other. And they actually want to, and they're doing adaptations and referencing the other models as they're doing theirs so that the staff really understand how everything fits together. The last thing I'll say is that, because I could go on and on about this, is that I think we also have to be really committed when we bring new practices in to doing the hard work. We call it we always talk about what we're going to start doing now, but it's really important to talk about what we're going to stop doing. So we have this conversation we're having with our folks around, we call it 3 things: do more of, start doing, and stop doing. So there's certain things like we're rolling out a practice in one of our transformation zones, and we committed to the staff that when that practice goes live, and it will in September, there's 5 things they currently have to do that they won't have to do anymore. forms, tools, et cetera. And that's a rarity in our agency. Usually it's been a layering on effect. We don't peel back forms, we don't peel back tools, and then the staff at the front line has no idea how this fits together and really no idea why they do certain things that they do. So we're really committed to doing that, and it's kind of hard because actually our policy folks initially had a little bit of an issue with it. They've come on board. Now our frontline supervisors actually have come to rely on like some of these forms and tools that, so there's a little resistance there to letting go of that. It's a little bit of you let go of one, you're in a trapeze and you got to let go of one rope before you grab the other. So it's been an awkward transition for people, but I think we absolutely have to do it, or we just overburden people and these practices aren't actually going to work.
Great. I'm sure there, as many former line workers in the room, we're grateful to hear that some of our leadership across the country understands that something has to stop in order for something to start. So caseworkers are applauding Missouri all across the country, Tim. So thanks for that. Just want to touch a little bit. Our panelists talked about workforce development and talked a bit about the turnover that we all experience in our workforce, and this idea that you really got to put some capacity in place to be able to sustain not only evidence-based practice, but also for your incoming workers and supervisors to understand evidence-based practice and what it's all about in your system. So I'm wondering I don't know if I have any sort of training directors or other type of folks in the room that are really already thinking about, or maybe folks from schools of social work, about how they're going to sort of underpin their workforce development so that this idea of evidence-based practice in child welfare systems begins to have anchors to it. Yeah. Please hold on for a mic there. And can you introduce yourself real quick?
Yeah, I'm Ted Cross. I'm actually a program evaluator with the Wisconsin Title IV program. I think this is relevant. I was involved in doing site visits to some of the counties and interviewing workers about their practice. And one thing I struggle with is how do you assess use of evidence-based practice in program evaluation. And I asked the workers what evidence-based practices they were using, and they looked at me like, I don't know what that means. So, and then when I knew a few that had been, people had been trained on in the States, when I asked about specific models, they were able to answer that. So I wonder to what degree understanding the term and understanding the concept of an evidence-based practice is an important part of workforce development.
Anybody want to respond, or the panel want to respond to those thoughts? Thank you.
Hi, I'm Anita Barbie. I'm at the University of Louisville in Kentucky, and several schools of social work, other than ours, I think Maryland is one of them, integrates evidence-based practice into the curriculum for the bachelor's and master's students, so that and we've found in our community and across the state that because of that emphasis, people are ready, whether it's child welfare, mental health, all the different systems. They understand the language now, and they're much more open to adopting not only the practices, but the rigorous evaluation using RCTs and QEDs. So we've found over a 10-year period a huge shift in the whole culture. And so it can happen. It's just that the schools have to have that will to do it. And then in our state, in our child welfare system, it's reinforced in the training. So
Great.
That's one state that's done it.
Thanks for sharing that, Anita. I'm aware that we have, I'm standing between you and your lunch, but I am going to make you work a little bit harder. And I want to sort of throw this back to the panelists, particularly New York, that has worked with so many providers related to bringing, as you heard, 30% of their caseload sort of being served by evidence-based, evidence-informed. Am I right?
On the
She's nodding.
preventive side, yes.
Yes, on the one side of the house, which I think is pretty impressive at this point. But I know that it hasn't been without challenges in terms of trying to deal with providers, and particularly around some issues around accountability and how do you deal with that maybe when you are sort of in the early stages and don't necessarily have contracts in place and other things, but maybe when you're seeing shifting of the work that's going on, and you need to have those accountability conversations. Carrie, can you speak to that?
Sure. We have a pretty structured accountability mechanisms already in place in New York City to monitor our providers. So we have contracts with providers, and we delegate out case management responsibility. And so we actually amended contracts to include the use of evidence-based models. So as soon as we agreed to a kind of partner and transition within existing contracts, we did amendments. Some other EBMs, we procured new contracts for those. But within the contracts, we set the expectations around fidelity to the model. And so from the beginning, it was clear that we would be using the fidelity data in our monitoring of the provider agency. But we really took the time to inform ourselves about implementation and how fidelity kind of grows over time. And the developers for many of the models educated us as well, and that was part of their orientation and training. And so we start with new programs and program development, so it's a little less intensive monitoring. And so they're not scored. We have an annual scorecard, and where everyone gets a grade. And for kind of the first year of implementation, they're in this kind of more supportive environment where we can really still look at data and hold them accountable, but they're not necessarily scored for it because we know there's a learning curve. But we are really paying attention during that time because it's really critical in terms of ensuring safety, and all the important pieces of child welfare work are paid attention to during the learning curve. It actually includes really intensive, frequent conversations, looking at data and identifying kind of which data measures we want to look at what basis. But at one point on the foster care side, Ina's team was having twice monthly calls with each agency to talk through performance data and check in and provide support. In addition, ACS, for every model that we've implemented, have had monthly provider meetings, so everyone implementing that model would come together and had monthly calls with the developer. And so it's really about everybody looking together at the information to hold providers accountable, but also knowing that we have a big role in this in order to provide technical assistance and support and make everything reasonable in terms of where they are with implementation.
Great. So I'm going to give my panelists one last opportunity to impart a pearl that they may want you to take away with as you walk out of the room. I'm going to take liberty being first. That's what the facilitator can do. So I just want to say that, again, a wealth of experience in this room, a wealth of experience on the panel. Take the opportunity over the next couple of days to really have some in-depth conversations, because as you know, everybody's either a 2012, 2013, 2014 cohort, where everybody's developmentally in different stages. But to the degree that you're one of the later cohorts, that you recently signed on to this thing, there's people that have plowed these fields, and you need to take advantage of them, because it will speed up your time involved in really trying to overcome some of these barriers and challenges. So please take advantage of that opportunity. Leslie?
So the pearl that I want to offer you is, there's a flyer on your table, and it's related to our model, which is called Partnering for Success, and the National Center for Evidence-Based Practice in Child Welfare is funded through a cooperative agreement with the Children's Bureau. Shout out to Melinda Baldwin, our federal project officer. We are working, as I had mentioned, with 4 jurisdictions, and we are soliciting interest from 4 additional counties or regions or state level child welfare behavioral health systems to implement our model. So we will bring that to selected jurisdictions at no cost, providing all of the components that we've talked about today to the child welfare and behavioral health workforce in partnership, and the model is described a little bit more in the flyer. So I'm happy to talk with any of you if you have questions or interested, but we're actively seeking applications.
Carrie and Ina?
I would say align early and often, because it never stops. And we put a lot of upfront effort into trying to align our standards with models before implementation and in early stages, but it's ongoing work, and it just keeps making the work stronger, and it's really rewarding, but it's time intensive, and it never ends.
And I think to piggyback on alignment, I would just stress being able to have those communication avenues and feedback loops, I think are very important. Carrie mentioned the calls that we have, and that really allowed you to learn a lot of qualitative data that was important in terms of making some of those other alignments and policy alignments possible. So I just think keeping communication with the model developers, the providers, and staff is key.
I would say, as I've been saying throughout the talk, that when we're dealing with the challenges that this work is going to bring, keeping a systems perspective, being willing to look at things that, where the systems are coming together, where child welfare is interfacing with mental health, I think is really critical. And I will borrow from a colleague who credits Uri Bronfenbrenner with saying this, but when you're encountering problems, be willing to look one level up. That often makes you look at yourself as a system and persevere.
Great. If everybody would join me in thanking our panel today.